Hello and welcome. I'm Vanessa Ho, and I'm a trauma surgeon at the Metro Health System in Cleveland and a member of the AAST Geriatric Committee. I'm here today with Adam Nelson, who is an assistant professor of trauma and critical care at the University of Arizona in Tucson. He's going to present a talk today giving an overview of geriatric rib fracture management.
Thanks, Dr. Ho, and I'm happy to present today. These slides put forth some much needed guidance for an important clinical topic. However, it's important to realize that they do not necessarily establish the standard of care. This talk is intended for community-based providers who are often the first caregivers for those with rib fractures. Objectives of this talk include recognition of the impact of rib fractures on older patients, understanding methods of triaging rib fracture patients in the emergency department, a review of multimodal pain regimens for rib fracture patients, including the role of regional anesthesia, and a review of the basic indications for surgical stabilization of rib fractures. First, a brief background about rib fractures and its impact on older adults. Rib fractures are the most frequently sustained chest injury from blunt trauma and are found in approximately 10% of all trauma admissions. Older adults who sustain blunt trauma have a higher incidence of rib fractures compared to younger cohorts, with falls and MVCs being the most common injury mechanism. Rib fractures are a marker of underlying injury severity and are frequently associated with concomitant thoracic injuries such as hemo or pneumothorax or pulmonary contusions. And in terms of morbidity related to rib fractures, it's pulmonary complications and particularly pneumonia that are by far the most common. And prediction of these complications, or which individual patients are most at risk, is an area of active investigation at trauma centers throughout the country. Looking a little more closely at the morbidity and mortality of rib fractures. If you look at all rib fracture patients, the overall rate of pneumonia is around 6%. However, in series focusing just on older patients, that rate of pneumonia climbs as high as 34%. That's 1 in 3 older patients with rib fractures who develop pneumonia. Mortality rates are generally high and also vary by age. Amongst younger adults, overall mortality is estimated at around 10%, and this is generally attributable to death from severe associated injuries. However, amongst older patients, overall mortality is much higher, around 20%, and is most often due to a progressive respiratory failure and pneumonia that is a direct result of the rib fractures. And in fact, in these patients, pneumonia has been described as the final common pathway to death after rib fractures.
So, knowing that rib fractures are often associated with high rates of morbidity and mortality, particularly for older patients, how would you suggest that providers know which individual patients are most at risk for having complications? Are there any effective ways to triage and risk stratify these patients?
That's a great question, Dr. Ho, and brings us into our next topic. So, given the high rates of pulmonary complications and death, particularly in older adults, it's important to be able to identify which individual patients are most at risk so we can more aggressively intervene with effective analgesia and pulmonary toilet. Now, one basic, straightforward predictive strategy involves the patient's age and number of rib fractures. And one of the first to show this relationship was Dr. Eileen Bolger in what turned out to be a landmark rib fracture paper in the year 2000, which is a retrospective comparison of elderly and non-elderly adults with rib fractures. And she found that elderly patients had much higher rates of both mortality and pneumonia. And for each additional broken rib in the elderly group, the risk of mortality was increased by 19% and the risk of pneumonia went up by 27%. And over the last 20 years, multiple series have been published with very similar findings. And additionally, over the last several decades, numerous rib fracture scoring systems have been developed in order to help identify patients most at risk and assist in their triage from the emergency department to help answer the question, which of these patients can go home, who needs an admission, and more importantly, who needs to go to the ICU. Now, I won't go over each of these scoring systems in detail, but the gist of them is that they are all retrospectively constructed and incorporate some combination of patient variables such as age, comorbidities, number of fractures, are they displaced, are they flail segments, pulmonary contusions, effectiveness of pain control, and the patient's breathing mechanics. One scoring system that I'd like to highlight in a little bit of detail is the Rib Injury Guidelines, or RIG, which were developed here at the University of Arizona and recently validated on a prospective cohort. RIG is a weighted scoring calculator with 8 elements that incorporate patient demographics, respiratory physiology, and anatomic findings, with scoring weights based on a prior multivariate analysis using death or ICU admission as an outcome variable. Once a patient's RIG score is calculated, they are assigned into one of 3 groups, which are used to triage patients from the trauma bay. RIG 1 patients are discharged home, RIG 2 are admitted to the floor, and RIG 3 patients are admitted to the ICU. Our validation cohort consisted of 1,100 patients with at least one rib fracture on CT. We performed a pre and post RIG implementation analysis and found that there were no readmissions for patients that were discharged home from the trauma bay. There were 2 unplanned ICU admissions for patients initially admitted to the floor. However, these were both related to alcohol withdrawal, not the rib fractures. We performed a multivariate logistic regression that showed that RIG implementation was independently associated with decreased ICU admission. There was a 1-day decrease in hospital length of stay with no overall change in mortality. So the rib injury guidelines appear to be a safe and effective means of triaging the care of rib fracture patients, and its use is associated with a shorter length of stay and decreased ICU utilization. Some strengths of the system include that it's relatively easy to use, widely applicable, and uses a set of objective criteria that really broadly encompass the patient's clinical situation. And perhaps its biggest strength is that it helps take the guesswork out of patient disposition when evaluating rib fracture patients in the emergency department.
And now that we've discussed which patients are at highest risk, let's talk about management of rib fractures. Dr. Nelson, can you take us through the principles of effective management for these patients?
Yes, absolutely. And the first thing I'll say, which is obvious but really can't be overstated, is that rib fractures hurt a lot. Patients tend to reduce their pain by minimizing chest wall motion, by reducing their tidal volume and coughing effort. And this is problematic because it leads to splinting, alveolar collapse, and poor secretion clearance. And this is really how we cycle into pneumonia. I can't tell you how many times I'll come upon a rib fracture patient who is lying in bed and says, "Oh yeah, the pain is just fine as long as I hold perfectly still." And this is not what we're going for. These patients need effective pain control so that they can have good pulmonary toilet, get mobilized, and up and out of bed. And also key is to set expectations with patients. These patients, especially some of the more tougher or more stoic folks, tell me it's just a rib fracture. And so I have to go over exactly why I'm worried about them and set expectations for mobilization and pain management. I think the key word for pain management in rib fracture patients is multimodal therapy. And the mainstays here consist of scheduled Tylenol, a scheduled NSAID, either ibuprofen or Toradol, and an on-demand narcotic, generally an oral version plus an IV for breakthrough, either in pushes or a PCA. And keep in mind that obviously folks can't go home with IV medications, so we will need to transition all of their medications to an oral regimen before they leave. There are a few multimodal adjuncts available for rib fracture patients, which often include gabapentin and a muscle relaxer such as methocarbamol. Other options include lidocaine patches and ketamine or lidocaine infusions. Now to the right here is our center's default multimodal regimen for adults with rib fractures for reference. For older patients with rib fractures, there's a number of additional points to discuss. namely delirium. And I think if you take an older patient with perhaps some underlying comorbidities and give them a trauma burden and put them in the ICU, well, delirium becomes nearly universal. And so you really have to mitigate this the best that you can. One thing to keep in mind is that pain causes delirium, and so you have to treat the underlying pain in order to treat the delirium. Another thing to remember is that delirious patients won't ask for pain medications. And on top of this, there's a hesitancy to give narcotics to delirious patients out of a fear it will make them even more delirious. I find that for older patients with rib fractures who are delirious and have a really good reason to be in pain, oftentimes what they need is multimodal mainstays of therapy plus a scheduled low-dose narcotic in order to take the guesswork out of when they're in pain. Another thing to consider is that you really need to exercise caution with some of the non-opioid adjunct medication. For example, gabapentin seems to be quite deliriogenic for older patients, and so we tend to avoid that unless it's a pre-existing home medication. Muscle relaxers like cyclobenzaprine and methylcarbamol are another example. And now on to the next part of our talk, which is regional anesthesia. There are a variety of catheter-based blocks available for patients with rib fractures. Epidural and paravertebral blocks are the most common and most well studied, with some newer interfascial plain blocks such as erector spinae and serratus anterior blocks as well. Keep in mind that there is no randomized controlled trial that compares the different regional blocks to each other. In general, though, regional blocks are highly underutilized, with one study from the National Trauma Data Bank showing that only 3% of patients who might benefit from regional anesthesia actually received one of these blocks. Now, thoracic epidural blocks are by far the most well studied. They provide bilateral pain control, improvement in analgesia with reduction in opioid use is well documented, with some evidence that they're associated with shorter length of stay, reduction in pulmonary complications, and mechanical ventilation days. Note that hypotension is common as an adverse effect. Paravertebral blocks are also commonly employed. These provide unilateral anesthesia, and so they're only good for one-sided fractures. They are less well studied, but available evidence suggests that they are equivalent to epidurals in terms of anesthesia and reduction in opioid use. Note that the spinal space here is not directly accessed, and so there is less risk of accompanying hypotension as a side effect. The last type of block I want to mention are interfascial plain blocks, such as the serratus anterior block or the erector spinae block, which have garnered quite a bit of interest recently and have been increasingly used in our center by the regional pain team. They're a little bit easier to place technically, and there's much less risk of systemic or central adverse effects. However, there really isn't much data out there yet about their effectiveness compared to epidural and paravertebral anesthesia. Now, type of regional block aside, I think the important question to ask is, when should regional anesthesia be used for rib fractures? And these are the answers that I came up with by distilling the guidelines and literature. Number one, pain that is refractory to your multimodal pain regimen. The patient is on all of the available agents, perhaps maybe plus a ketamine drip, and their pain is still uncontrolled. Number two, and this is the most common reason that we use it, which is early consideration for patients who are high risk. And this may be because the fractures are just horrible, there's flail segments, ribs are displaced, or it may be due to high-risk patient factors such as older age, frailty, or presence of comorbidities. These are the patients that really cannot tolerate a lot of physiologic or respiratory distress, and you really should preempt some of the issues that they are going to have and get a regional catheter placed as early as you can. And lastly is a deteriorating clinical picture. This is the patient who's splinting and starting to have respiratory distress. However, I will tell you that in this case, the ship has probably already sailed, and while a catheter may still be a good idea, it probably won't save them quickly enough to avoid intubation at this point. Here's a few other important considerations to touch on. Number one, is pulmonary volume expansion techniques. And there's many different ways to do this: coughing, deep breathing, incentive spirometry, intermittent CPAP, something to regularly help re-expand the collapsed alveoli. The second one is early mobilization. These patients need to get up and out of bed, sitting up, getting to a chair, and walking. This all promotes natural deep breathing and lung mechanics to help offset alveolar collapse. Number 3 is chest tubes that were placed either for a hemo or a pneumothorax. These are really quite painful and can worsen respiratory mechanics, especially if they're the large bore surgical chest tubes. Creating protocols to focus on early removal can help get tubes out so that patients can be more comfortable. And lastly is pulmonary contusions. Keep in mind that the bad ones blossom and get worse over the first few days as inflammation and swelling set in. Often patients with contusions will get worse before they get better, and it's important to try and anticipate this. I think one thing that can help with contusions is to be really judicious with fluid management. Giving extra intravascular volume is best guided by dynamic parameters such as passive leg raise or stroke volume variation rather than blindly giving boluses for low urine output. Now, the last part of this talk will focus just briefly on a few concepts behind surgical rib fixation. Performing rib fixation involves the creation of a thoracotomy incision, getting down to the chest wall, realigning the broken ribs, and then fixing them in place with a set of titanium plates and screws. There's a variety of different systems available. The picture shown here is a system that we use, which is just a straightforward plate and screw system. Now, rib fixation is interesting in that it's been around since the early 1970s, and yet the indications for rib fixation are still quite controversial. And part of this is because many of the studies, especially the early ones, have very few patients, which has made it difficult to draw many meaningful conclusions. Now, all that said, here are the currently supported indications for rib fixation. Number 1 is impending respiratory failure secondary to displaced or movable ribs. And this includes patients with flail chest or severely displaced non-flail segments. And I think this is one of the strongest indications, as these patients really need to have chest wall stabilization in order to have reasonable respiratory mechanics. Number 2 is a significant chest wall deformity. And number 3 is on the way out fixation. This is when a surgeon is already in the chest for another reason. Most commonly, it's because they're doing a video-assisted thoracoscopic surgery for retained hemothorax, and there are severe rib fractures that can be fixed while the surgeon is already there. Now, in properly selected patients, rib fixation does improve respiratory mechanics and reduces pain. However, a key finding is that rib fixation needs to be performed early, in the first 48 to 72 hours, really, in order to get the benefit.
And this has been a really great review for community providers caring for some very challenging patients. And wrapping this all up, Dr. Nelson, what do you think are the big take-home points?
Thanks, Dr. Ho. So here's our takeaway points. Number 1, rib fractures carry high rates of morbidity and mortality, with high rates of pulmonary complications, particularly among older adults. Number 2, there's a number of rib fracture scoring systems available for use. The rib injury guidelines are an easy-to-use, objective, well-validated system that assists with triaging rib fracture patients in the ED. Number 3, the key for effective pain management is multimodal therapy, including liberal consideration for regional anesthetics, especially in high-risk patients. And lastly, early consideration for surgical stabilization in select patients who are most likely to benefit from this intervention. And I'd like to thank the AAST, the Geriatric Trauma Committee, Dr. Vanessa Ho, and Dr. Bilal Joseph for their assistance in preparing this presentation. Thanks again for watching.